Good morning. What we're talking about today may be a new concept for many of you. For 20 years, Baylor College of Dentistry in Dallas asked me to give 10 two-day hands-on seminars on this topic, comprehensive dentistry, because the concept of comprehensive dentistry is kind of, according to the dental school, has kind of been lost. With all the corporate dentistry, it's gone to toothache dentistry. So what I'm talking about with dentistrymasterclasses.com is comprehensive dentistry and how to do it and what you need to be able to do to accomplish comprehensive dentistry. So this is the first of potentially many webinars, depending on how this goes, on all those 20 years of seminars. So as we go through this morning, this is going to be dipping your toe in the water. There's so much material, it would take me many of these webinars to go through it, which we're prepared to do if people are interested in knowing how to do comprehensive dentistry and knowing how to do complex restorative cases. What I want to do initially this morning and with the next few webinars, if we do them, is make you as good as you can be and as productive as you can be with those things you know how to do based on your technical training. You can't know how to do the cases I know how to do because I have so much training, I've had so many fabulous mentors, and I've been doing it for over 40 years. You can't know how to do it. So don't even try right now. What we want to do is make you as good and as productive as you can possibly be with your technical expertise and your personality, training, and basically what you know how to do. So the objectives of comprehensive dentistry are to restore the dentition and supporting structures to optimum or desired health, function, comfort, and aesthetics. Such a big part of my practice is the conversation. We debated whether we were going to show you our numbers or not in the practice, and the vote on the staff was to show them. It's like when I had the seminars at CARD in Dallas. The dentist wanted to see the numbers. It's kind of hard for me to do that because I don't want to be, make a big deal out of that. But to give this system credibility, I understand why the dentist at CARD wanted to know what the possibilities were. So at the end of this seminar, I'll show you our numbers for the last 5 years. So when you say to restore the dentition and supporting structures to optimal desired health, function, comfort, and aesthetics, I love a good story. I love to hear a good story, and I love to tell a good story. And a lot of my practice is telling of stories. And I'll ask a new patient, if you were driving a car to California or Alaska, what part of the car would you want to work? And I'll say, this is not a trick question. And someone will say the engine, and someone will say the tires. I'll say, well, what about the windshield? What about the air conditioner? And then they'll come up with the answer, the whole car. And so that's what comprehensive dentistry is. It's analyzing the whole car, fixing the things that are broken. I always say that function is something most thinking people want. They want good function, just like they want that in their car. They may not have to have a perfectly good paint job, but they want the air conditioner, the tires, the windshield, the engine to work. And so most thinking people want functional dentistry. The cosmetic part is a second tier thing, but most of them want functional dentistry. And then I say, if you also want cosmetics, we can talk about that too. But the other thing I tell patients is it's really not about you, it's about me. Because I'm not going to have a case of mine walking around out there that I'm not happy with. That's why I don't really patch things up, because a patch up is going to fail, and then the patient's problem is my problem. So I'm not against people patching things up, but just know you're going to run into probably greater problems down the road. And I don't ever want a patient to say, Dr. Cutbirth, you just fixed that tooth and I broke it at a party this weekend. Well, if you didn't fix it, if you put a big filling in the tooth, nothing's holding the tooth together, and they bite down on it, they're going to fracture it. So I don't like conflict. I don't like misunderstanding. So at my stage of the game, I fix things. I don't patch them up. You're not bad if you do patch them up. But again, I'm going to show you today what I do and what I've been doing for the last 40-something years. It begins with the word cell has no place in the dentist-patient relationship, or in the medicine-patient relationship. I don't want to talk somebody into something. But to do it this way, you're going to have a different model. And that's what you're going to have to work out. If we go through more of these webinars, I'll tell you how dentists at my teaching center converted their practice from a toothache practice to a comprehensive practice. We won't have enough time to go into that today. But if you decide to do it, you've got to think differently, and you've got to be brave, because everybody else is going to be doing toothache dentistry. Hey doc, I got this tooth, and fix that tooth. Well, they've got 5 to 10 other teeth that are also bad, again, also going to have the problem. So I've really set our practice up the way I would want somebody doing it for me. Meaning, I don't want to be worried when I'm on a trip somewhere about a tooth breaking. Doesn't mean everybody has to fix all their teeth, but I want us all to know about it from the get-go. Comprehensive dentistry doesn't mean doing something to every tooth. It means, just like the car, fixing the things that are broken, that aren't running effectively, so the car can drive to California or Alaska. So this is what our objective is: to perform those services to each patient appropriate to their temperament, circumstances, and objectives. Now, the other part of that is, in my practice, it's got to be something that I'm happy with. It doesn't mean they have to restore all their teeth. It just means whatever we do restoratively, we may do it in parts, we may do it all together, depending on their temperament and circumstances. But I'm not going to do things that I can't stand behind. So we must educate each patient so they appreciate and understand dentistry and can make informed decisions regarding their dental treatment. They must be able to understand and assist with their dental diagnosis and treatment planning. Now, this is my wife Sharon, and this is me years ago. And this was a friend we made. I think you grabbed a hold of his dorsal fin and rode for a little while, didn't you, Sharon? Okay, so what we're talking about in this seminar, and if we do more of these webinars, is what is a comprehensive practice? And what do you need to do to be as productive as you can be appropriately with what, according to your training and expertise and experience. Then, if you want to get better, learn more techniques, I've got all these videos in dentistrymasterclasses.com. Subscribe to dentistrymasterclasses.com and watch the videos on everything from all types of surgery. I was in a surgery fellowship for 2 years at Baylor Dental School. Full mouth reconstructions, veneers, crowns, composites, worn teeth, treating TMJ, treating myofascial pain. These are not things you just wake up one day and say, you know what, I'm a good dentist. I'm a good dentist. I know how to do all these things. It's like golf. You don't just wake up one day and say, I'm a good golfer. It takes training and experience. So that's what I'm trying to do with dentistrymasterclasses.com. Okay, so this is my comprehensive practice system. And I've had some wonderful mentors along the way. I began the first week of my practice out at the Pankey Institute in Florida with Dr. Pankey. And he introduced me to the idea of comprehensive dentistry. It was a fabulous teaching experience. And I was on the associate or the visiting teaching faculty out there for 15 years before Baylor Dental College asked me to set up an advanced teaching continuum at the dental school back in 2000. Can't believe we did that for 20 years. 10 two-day hands-on courses a year on everything from the most basic things, including our dental practice system, to the most complicated, full mouth reconstructions with implants. I've got lots of planet training in surgery and restorative dentistry. So what we're talking about today, the beginning part, is how to double, triple, quadruple your dental practice productivity without selling. Remember, we're not selling anything. So this is how I do it in my practice. I came up with this system years ago, and the way I came up with it, I thought, how do I communicate to a patient? How do I put a patient into a situation that they understand precisely what their dental condition is and what their options are? How do they understand precisely what their dental condition is and what their options are? With the time, based on the dentists that were coming to Card, or Card wasn't set up at the time, most people, and most of you probably do the same thing. You see a patient back in the operatory, and you say, you've got a cracked tooth, or you've got a broken filling, or you've got decay, or you've got this. Well, that goes right over the top of a patient's head. They have no idea what you're talking about. And they go, yeah, right, but they don't grasp the need to fix it because they don't understand it. I'm a visual learner. If you tell me something, it may go right over the top of my head, but if I can see it, I understand it, I own it. So that was my concept. So I started taking diagnostic photographs of patients' cases at the new patient exam. So I'll talk about how we do that either today or if we do another one of these in our next webinar. So this is the basic system. This is the fundamental of entering my practice. I don't do any definitive work on patients without a comprehensive exam. Why? Why don't I just treat that tooth and do a root canal and a crown on that tooth and then worry about the rest of the teeth later? Because like that car, the patient's driving to California or Alaska, it's all connected. What if the person has a TMJ problem and you keep their mouth open for a couple of hours doing that root canal and crown, and it exacerbates that TMJ problem? I've seen patients in my practice that had that happen. Luckily not in my practice, but they'd gone to a dentist, he'd done some work, they had a TMJ, an anteriorly displaced reducing disc that became an anteriorly displaced non-reducing disc. Well, I can fix those, but if you're the dentist that did the filling on the tooth, you see what I'm saying. What if they have periodontal disease and bone loss? You're responsible for that patient, at least in Texas. If they come in and have dental work done, you're responsible for their dental condition, and you don't diagnose it. What if they have mobile teeth? What if they have subgingival calculus? All those things. I've set this up the way I want to do it for thinking people, because a thinking person, or most thinking people, want to fix their teeth. If somebody just wants somebody to take out a tooth, you're not a bad person if that's how you practice. But I don't want to be that person. I want to fix a condition, or at least have a plan in place to fix a condition so the person could drive the car to California or Alaska. So these are the three things we do: new patient exam and interview, the new patient comprehensive exam, and then a separate consultation from the new patient exam. Why a separate consultation? I want to have a chance to analyze the data from the comprehensive exam, and then I'll type out a consultation sheet which states, and I'll show you these in forthcoming webinars if we do more of these, what the patient's complaint was. What did they say when they came into the office? What got them there? You know, I have toothache, or I've never liked going to the dentist, or I've got, my teeth are mobile, or I'm grinding, whatever it is. So I write that down, and I write that down, type it up, so the patient knows I heard what they said. I heard what they said. Then I'm going to write examination results. And then I'm going to write recommended treatment based on the new patient exam information. And I'll show you that in a minute. Then we're going to have this separate consultation. So this is the new patient interview. Well, why do you want to interview a new patient? I'll talk about this a little more later on. I want to know who's connected to the teeth. I want to know how did you happen to pick our office? If somebody says, I just picked you out of the phone book, or if they do these, what are they called when they're on a list of dentists? What's that called?
Oh, their insurance company, like you're in my network.
Oh, in or out of network. We don't do the network thing. They've got to pay you something, but I don't subscribe to the network. If somebody tells you, I just came to you because you were one of the dentists on my list, well, those are not real strong patients. They're just picking a dentist that's close to them or on their card. I'd prefer to have patients that are referred by a very good patient that had their teeth restored, and they're saying, this is the person to go by. So I want that information in the computer. So I'm clicking, who is this? Then I want to say, tell me about your problems. What's your dental history? What issues have you had in the past? And my father was a small town general medical practitioner. And he always told me, if you listen to your patients, they'll tell you what's wrong with them. And I'm writing this down as they tell me. Just all those things. We'll go in forthcoming webinars, if we do those, I'll go through in more detail exactly what I talk about. So that's the first part. The second part is the comprehensive exam. Now, Pam's been with me for 42 years, and she generally does the initial part of the comprehensive exam. What is that? It's a full mouth set of radiographs, periapicals and bite wings. Now you can do a pantograph and 7 vertical bite wings. I like a full mouth set of radiographs, bite wings and PAs, because you're looking at a tooth on more than one radiograph. And remember, a pantograph is a scalp film. It's not going to really diagnose subtle decay. So I prefer a full mouth set of radiographs, then a comprehensive exam. And what's in the comprehensive exam? We're not going to cover all that today. The comprehensive exam is checking the periodontal condition, the soft tissue, the muscles of the face, The intra-articular condition, the TMJs, do they have a pop and a click? What's a pop and a click? That's an anteriorly displaced reducing disc.
Steve, can you raise your voice a little bit when you're talking?
Yeah, that's an anteriorly displaced reducing disc. What if they can't open their mouth past about 20 millimeters? Well, that is either a closed lock, an anteriorly displaced non-reducing disc, or it's a myofascial condition. There are ways to tell what that is. We'll talk about MRIs. There's so many things to talk about, but we're not going to go through that today. So we're going to do a comprehensive exam and full mouth set of radiographs, and then I'm going to take diagnostic photographs of the teeth. Because remember, if the patient can see it, they can understand it. If you're trying to diagnose them and tell patients what they are back in the operatory, forget it. You're going to have a toothache practice, and you're going to see 10 to 20 patients a day, toothache at a time. This type of comprehensive practice evolves into longer appointments, more comprehensive appointments. You're not selling anybody anything, you're fixing the car. And you can do multiple things at one time that the patient has diagnosed themselves. They understand it when you get to the end of this diagnosis and treatment plan, and they ask for it. That's the idea. I try to never say you need. I may recommend things, but they've got to want it. Okay, so new patient exams, a full mouth set of radiographs, a comprehensive exam, and then diagnostic photographs. Pam does that. Now, if there's time between me coming into the operatory for the exam and the end of the examination material, then the assistant may go through the picture books. I don't care if you get these picture books or not, but if you don't have them, no, I feel sorry for you. If you don't have something like this, I'll show you here in a minute how they fit into this diagnosis or into the comprehensive exam. I published these books so I would have something for my patients to show them what pathology looks like and what a restored situation looks like, so they can understand what they're looking at when they look at diagnostic photographs of their teeth. Okay, so then we do the co-diagnosis. As I said, Pam's been doing this for 40-something years, so she writes down what she sees. Now, the assistant can't make the diagnosis, but she can tell me what she sees. Then I'm going to go through and look at the entire dentition. I'm going to check lymph nodes of the neck. I'm going to check muscles of the face, TMJs, popping, clicking. I'm going to do an oral cancer exam. Then I'm going to check the bite. Do they have a centric relation, centric occlusion slide? I'm going to put that with the TMJ situation and the myofascial situation. If they've got pain in those muscles, have they got worn teeth? If they do, what does that mean? They brux. They're bruxer. Do you have a night guard? One thing leads to another. I tell patients, I'm really Sherlock Holmes. I'm more of a detective. Sometimes I think I'm more of a detective than a dentist, and I'm a home remodeler. I'm not a home builder, I'm a home remodeler. And that's how this system fits together as we talk about it more this morning. So this is the co-diagnosis, and Pam is telling me what she found. Now remember, Pam is on the patient's team. I'm not the opponent. I mean, I know they like me, but when they hear the thing broken, she's got a broken filling in number 3. She's missing a tooth in number 4. You've got a leaky filling in number 29. That resonates with the patient. They're hearing that from someone that they think is totally neutral. And so Pam goes through that, and I'm saying, yes, I see that, or no, we'll watch that, or whatever I'm saying. But she's not diagnosing it. She's just telling me what she saw. And Pam knows more about dental treatment probably than most dentists. She's heard most of the seminars I've ever given, and like I said, been working with me in my office for 42 years. Then I qualify the patient. Now we've done the co-diagnosis, and I'm going to push back in my chair. And if there's a lot of things, if it's an abstract case, I'm not doing the consultation, but I don't want to spend a lot of time putting a consultation together if somebody's not interested in saving their teeth, they're not interested in driving that car to California or Alaska, and they're rubbing their first two pennies together, because I tell them the thing that is tough about this is I've got all these mean people working here, like Pam, Joanna, Josh, Bo, Casey, Lori, and they all want to get paid. And we've got those mean old lab bills. So we can fix anything. I've got the training and the experience to fix anything. But unfortunately, somebody's got to pay for it. And they usually chuckle, but it just gets that out in the open. And they'll say, well, what do I need to do? And the abstract cases are the trickiest, and that's where the conversation comes in. Because I'll say something like, depending on how good you want it, you could put a car in your mouth. What kind of car? Well, it depends on how good you want it. We live in America. You can get it as good as you want it if you can find somebody like me that can fix it. So that's what we'll talk about at the consultation point. But it kind of warms them up to where we're going if it's a train wreck. Another thing I'll say is we see a lot of so many comprehensive cases because people want to find somebody that knows how to fix it. Now, if it's a train wreck, meaning they're missing teeth, they've got broken teeth, they've got lots of decayed teeth, they've got periodontal disease, I may say it's like a house. And sometimes you've got a house damaged by a hurricane. And the roof's blown off, the walls are soaked, the carpet's soaked, the floors are soaked, they had termites to begin with, one of the rooms is blown off, and there's a point you take 3 bulldozers at the curb, knock the house down, and start all over. And in those cases, I'm setting it up to talk about either all-on-4 or implant-supported removable dentures. Now, I personally don't do just plain dentures. I'm not against them. I'm rooting for you if you do plain dentures. I just don't want to do it because I don't want to deal with most people that have dentures that I know that are never happy with them. You're seeing them all the time to make something, try to make something fit that doesn't fit, especially if they've got a flat ridge. Now, some of you may be really good at that, but all I do, if we're taking all the teeth out, is either implant-supported removable dentures or all-on-4. But I'm kind of teeing it up right here so the patient knows what we're going to be talking about in general when they come back to the consultation. And that's why I always say at every seminar I've ever given, it's about the conversation. It's about the conversation. At the interview, patients are usually nervous, and so they'll come into the room and sit down, and normally I'll tell a story about something just to kind of break the ice and loosen them up. Then they'll tell me a story that's related to that. It always tees it up, and they're ready to tell a story. So at that point, you have some type of relationship before you get into why they're here, the dental part. And it just relaxes people. If you can tell a story, and then they can tell you a story, there's something about it that just relaxes them. I know when the few times we've had change in the staff, I know when a staff person's first starting, they're saying, come on, let's get with it. I know they're thinking that, but after a while, I think everybody realizes that's just a part of it. I grew up ranching in West Texas, and I remember going to cattle auctions with my grandfather, my uncle, my father, and you have these two old guys just standing there, sitting there, and this guy'd want to sell some cattle, and this guy'd want to buy some. And they'd start talking about anything but cattle. And before you know it, they'd gotten down to it, and they'd work something out. So don't get in too big a hurry. All right, the new patient consultation. Now, remember, I want the patient to know what pathology looks like. What is pathology? I want them to know what restorative options are out there. And so I'm going to use these books. This is restorative options, and this is dental diagnosis. This is pathology. And we're going to look at these books first with the patient, and then we're going to look at the photographs and the radiographs of their teeth. Are you getting the picture here? They're going to know what pathology and restorative options are like. Then they're going to look at their teeth with the objective being they have enough information to diagnose themselves. So always when the patient comes in for a consultation, I'll push back and just, again, tell a story, or talk about something. Say, well, how's things going today? And you don't want to ask bad questions. Like you don't ever want to ask a woman, do you have children? Do you work? Unless you know the answer to that question before you ask it, because it's none of your business. Now, I'm looking at the health history when they come in on the interview, and it'll say, are they married? Part of it is, do you have a job? What's your place of business? And so if it comes off that sheet, it's good to ask. And then I may say something like, what moved you to Austin? Or I live in Waco. Or what got you to Waco? And she may say, well, our 2 kids, we want some help with the children from our grandparents. So now I know she's got children, so I can ask those questions. But don't jump right into that. If you want to get tattooed stupid across your forehead, ask somebody questions that you don't know the answer to that's going to make them feel uncomfortable. But I want to chat about something like, I know now what got her to Waco, so this is the second appointment. The first appointment was the interview and the comprehensive exam. Now this is the third appointment for the consult. And so I've got a lot of information on her from those first 2 appointments. So I never start right in with it. That may be your style to just get right with it from the get-go. But I always chat for a while, or I'll tell them something funny that happened that day. Or I'll say something like, you think my claim to fame is being a dentist. I was bit in the face by a shark 5 years ago. And that just something to kind of change the mood, or anything. What do you like to do when you're not working? Something that just gets them in a free state of mind. And many times we'll talk about a million other things and just talk about the dentistry for kind of a short period of time. But because we have that relationship and trust, they're not having to change a mindset to know what I'm telling them is the truth. That's what I tell people. I said, I'll never tell you something that I don't think is the truth. So first, we go through the picture books, the dental diagnosis and the aesthetic restorative dentistry. Then I've got plaques and models of different things. This is implant-supported denture. This is a root canal. You can see I've got her photographs up on the screen. We'll go through those. So these books, I can't live without. I don't know how anybody does a consultation without these books or without this system. Now at my teaching center, or when I've given seminars, dentists have always said, oh, my patients won't come back for a consultation, or they won't have an hour-and-a-half exam. Baloney. What's a person's favorite topic? Themselves. Think about if you went to your medical doctor and the medical doctor was confident And he said, I want to give you the proper treatment. I want this to be the treatment that's appropriate for you. So today we're going to examine you. Then I'm going to go over the examination results, and then I'm going to have you come back to an information appointment, and we're going to go over that once I've had a chance to analyze it. Well, doesn't that make sense? I mean, if he said, I'm going to look at it right now and diagnose you, and it was something complicated, I wouldn't probably have as much confidence that it was a good diagnosis and a good treatment. I would appreciate it, and I find that's what my patients do. Josh and Bo, I don't think we've ever, or Sharon, have we ever had a patient said, oh, I don't want to come back to a consultation appointment? Ever? Ever. And I've been doing this over 40 years because that's their favorite topic. And if you present it as it should be presented, I can't get all this information and diagnose it, and I want to write it up on a consultation form so they've got a written copy of what they said when they came in, examination results, and the treatment plan. Now, the treatment, whether it's stages or all at one time, depends a lot on what they told me when I was qualifying them. Meaning, where are we with this? Are you do you have a trust fund? You want to fix it all at one time? Is that a lot of money for you? Is it not? What are your objectives? I want to try to tailor this for your temperament and circumstances, and that helps me with the consultation. Just think about this. It's like home remodeling. If somebody is remodeling your house, what do they want to know? Number one, they want to know what you've got in mind. And so if you say, I want to knock out these walls, I want to redo the kitchen, I want to, do some big stuff, you're going to say probably what I do. You have picked the right person to do this because I can fix anything. Now, if you do that, what's our budget? You're going to put a car in your mouth, or you're going to da-da-da-da, whatever it is. So you're setting it up so you don't have this big plan worked out for the patient, and they think they're going to spend $1,000 or $5,000. I say, I wish it was that way, but we've got all these people working here and all these labs and all this overhead, and I'd like to make a few quid from this. And so if you do all that, you're going to put some kind of car in your mouth. Just qualify them so you know what you're doing, what you're getting into before you put the consultation together. When I was younger, I would just go straight from the exam to the consultation and figure out this big comprehensive plan fixing all the problems. And the patient would say, oh, I've got $1,000 burning a hole in my pocket because I didn't know, I hadn't qualified the patient. I didn't know what their objectives were and what their circumstances were. So, as you do this more, you'll get more comfortable with that part. I'm just telling you what I do. Okay, so we're going through the books. I'm going to show you these books in a minute, and I've got the patient's photographs up here. And so this is the dental diagnosis book. And you may have another book that does this, but I'm going to show you what's in these books. And I published these back in 2000, so the dentist at my teaching center in Dallas would have the books. I just had them in notebooks at the time. So I said, I've got to have the books so they can do the interview, exam, and consultation. So we're going through the books first. And this is what's in the books. Some of the things. This is decay. And this shows what it looks like in the tooth. And then once I open the tooth, you can see this one, this little bit that you don't even see looked like that. This one that was a little larger looks like that. So that tooth was decayed into the nerve of the tooth, and I had to do a root canal and a crown. And I tell patients decay is like termites. It makes a small hole in the tooth and then blows up once it gets into the softer dentin. And I've also got plaques that show the interproximal and occlusal decay. Another case, just those little dots. This was a Baylor kid, and it showed I had to do 10 root canals and 10 crowns on him because it blew up. And he'd been going to the dentist, and he said, the dentist said, we're watching these. Well, what are you watching? Decay doesn't go away. It doesn't go away. And so you want to fill it as quickly as you can, as conservatively as you can. These are old mercury amalgam fillings, and over time they pull away from the teeth. And remember, the only thing holding mercury amalgam fillings in is mechanical retention. The bottom part, or the apical part, is wider than the coronal part, so they can wallow around in there for years. The coefficient of thermal expansion of a mercury filling is about 75 or 80. Coefficient of thermal expansion of a tooth is 11. That's how much something expands and contracts when exposed to hot and cold. So once you can see leakage around those fillings, or when somebody drinks hot and cold, that filling's going like that and the tooth's going like that, so it pulls away and you get leakage underneath it. So that's what was under that one. That's what was under that one. This one we could clean out before it got into the nerve of the tooth. This one was into the nerve of the tooth, so I had to do a root canal on the crown. This one we could do a composite filling. Now, the larger the filling, even a composite filling, the greater the coefficient of thermal expansion differential comes into play. So you can put this beautiful big mesial occlusal composite in a tooth, and it looks good at the time, but over time it's going to pull away from the teeth, especially if a patient drinks a lot of cold. It's going to contract much more than the tooth does, so you're going to have leakage around that filling. So I don't do big composite filling. If it's big, I put a crown on the tooth to hold the sides of the tooth together. This is showing a crack in the distal of that tooth, distal to the filling. Well, once I take the filling out, there's the crack. You can see the cracks into the nerve of the tooth, and that explains why the tooth hurts when the patient bites down on it, because it expands those pieces and it's painful. So that's when you have to do a root canal on the crown. So you're looking at cracks on teeth, and I'm not saying to a patient, you need to put a crown on that tooth. I just want to give them an evaluation of what I see. I saw a patient Thursday that 2 weeks ago I said, Scott, I'm not saying you have to do anything with this tooth, but you've got a big crack on the front and the back of the tooth. Now, if I didn't show him what that looked like, he wouldn't understand it. So I took a diagnostic photograph of it and showed him, and I showed him this picture. And I said, I'm not saying we need to do anything, but I would be really careful when I bite on that tooth. When you chew your food, the first few chews of any bite, chew softly. Because if you chomp down and there's a bone or a rock in those beans or rice, you're going to split a tooth, and especially that one. Well, he came back day before yesterday, and he'd split that tooth. So it's just, I'm the dentist of this person. I'm giving them information. They can decide what they want to do with it. And diagnostic photographs in these books are invaluable for that.
There's a link in the description where they can purchase the books.
There's a link in the description. If you want to purchase these books, you can purchase them. Like I said, you got to have something to show people what pathology is and what restorative options are. So what are we going to do? We'll put a link in the...
There is already.
Okay, there's a link if you want to purchase those. And again, I don't care if you purchase them or not. I'm just saying, if you want to double, triple, quadruple your practice, you got to be able to show people what you're talking about with these, and then you've got to have a good camera system so you can take the diagnostic photographs. I don't know if we'll talk about how to take the photographs and which ones they are in detail today. But if we do this again, I'll show you what those photographs are and how to take them. Okay, so this is decay under that crown. Remember, you can't diagnose this on a radiograph because the crown blocks out the decay. It's radiopaque. And so I'll show them it's like a termite going underneath there, and this is what was left of that. This shows chipped teeth, how you can fix it with bonded composite. worn teeth, how I fixed it with bonded composite. Remember, with bonded composite, you can't make the composite any longer than the longest part of the existing tooth. I can't make this composite restoration any longer than this part of the tooth. If I wanted to lengthen those teeth to here, you can't do that with composite. People are going to break it off. That's another reason why most of my patients have night guards, because most people grind their teeth at night. They brucks and have them take their finger and bite down on between their bicuspid teeth and say, bite as hard as you can. Say, what percentage of your bite do you think that is? Maybe 5%? Well, imagine when you're bruxing, clenching your teeth at night, it's 20 times greater than that. So you could bite through the bone if you could stand the pain. So if you don't want a night guard, great, thank you. You're like an annuity plan for my practice. But I'm doing this to try to help you keep your teeth with the least amount of problems for the rest of your life. Watch my video on how to keep your teeth for a lifetime. I go through things that everybody should do at an early age to preserve their teeth for a lifetime. Now this is aesthetic restorative dentistry. These are veneers on this girl's teeth, had big hypocalcification and we've restored them. This woman had old composites in the teeth and just discolored, so we've restored those teeth with veneers. These are veneers on her teeth. A chipped tooth. Now remember, if somebody has chipped this tooth, whatever you do to that tooth, normally you do the same thing to this one, because matching a single central is almost impossible. I worked with probably the finest technician in the world, Willie Geller, in Zurich, Switzerland for about 15 years. And Willie told me that. He said, don't send me a case that you've got a single central because you've got dissimilar materials and you're not going to match them unless it's an old farmer that just got off a tractor and it doesn't matter. But if you've got an attractive woman, most of the time, even though you'd rather not prep that tooth, you don't want her to be the girl with the tooth. So I put 2 veneers on these teeth. This happens to be my wife that was hit in the mouth by the boom of a boat when she was about 35. And so I restored these with Mr. Geller years ago. This woman just had some old porcelain to metal crowns that were leaky and metal margins. So we changed them. This woman had diastemas. This guy had severe wear. Now, what if you restore this guy and he doesn't have a night guard, or he doesn't wear his night guard? Write it down, write it down, write it down on the consultation sheet. Don't ever forget what I'm about to tell you. And I've said this in videos all through the years. If you tell somebody something ahead of time, it's a reason. If you tell them after the fact, it's an excuse. So with stuff like this, you don't want the patient to come in with broken teeth and he goes, I thought you just fixed that. Well, look what he's done here. And you think he's not going to do it again to these teeth? Restoring severe wear cases, I tell patients, is like restoring an Indy 500 car. You've got the finest mechanics in the world restoring those cars. But by the end of the race, they're just beat to hell. Because why? They're driving them so hard. Well, this is an Indy 500 card, so don't get into one of these cases unless you know you've got a patient that is compliant, unless he's got some money, because if he's done this, he is going to break some of these teeth in restorations. This guy's held up well, but he's broken a tooth, I know this upper right cuspid, at the gum line years later, and we had to place an implant. So tell patients in these cases, are you willing to take the responsibility for it? Because I'm not. I can restore it, I promise you, as well as it can be restored. But after that, you're on your own. If you decide not to wear your night guard, if you decide to bite hard things with your front teeth, I tell all my patients, even if they've got natural teeth, don't bite anything harder than a tuna fish sandwich or a hamburger with your front teeth. Why? Because with front teeth, you're pushing out that way. You're not biting along the long axis of the teeth like you are with back teeth. We'll see 2 or 3 people a week that have chipped their natural anterior teeth, just biting something hard. So that's why I suggest to people they have a night guard, and I'll show them the cases. I'm probably going to show you here in a minute of what people do to their teeth grinding. And so wear a night guard and don't bite anything harder with your front teeth than a tuna fish sandwich or a hamburger, even pizza and things like that. Cut it up, put it between your back teeth, because if you've got a thin edge on the front teeth, you'll break it. How many patients have you seen that said, I was biting on a sandwich and I broke that off? Well, that's because they'd sharpened it. They probably didn't have a night guard. They had that thin edge, and that sandwich was just the last link. Yeah, okay, so anyway, there's more. We'll go through these quickly. So once I've gone through that, then I'm going to put the patient's photos up here. Do you get it? That's why it works like this. You're not trying to sell. She's ready to diagnose herself.
For people who are just joining, we're not diagnosing in the hygiene room. We're doing a separate interview, exam, and consult.
Yeah, this is a separate consultation from the interview and comprehensive exam. Now, if we do more of these webinars, we're waiting to see how this goes, if people even want to do it this way. I'm showing you how I do it. I'll go into greater detail in all of this, as well as a lot of other things. We're kind of evaluating after this webinar to see if you want to do this again, because if we'll do it if you want to do it. If you guys don't want to do it, then one and done. Okay, so now I'm going through her photographs, and she's seeing on her photographs what she saw in the dental diagnosis book. The keys to, I don't want to put a lot of views up here, a lot of words up here. You want a neutral setting like your private office, absolutely not a dental operatory. If you're trying to diagnose people in the dental operatory for a comprehensive case, forget it. Quit watching the video if you plan on keeping doing that, because it's going to be a waste of your time, because it just won't work. They've got to understand it, and they're not going to understand it in a dental operatory. Now, if it's a cavity or something like that, maybe so, but if it's a comprehensive case, can't be done. Use these books or similar before and after books so you can show them that ahead of time, and then they look at the photographs of their teeth and they understand what you're talking about. Excellent diagnostic photographs of the patient's teeth, 12 views. If we do this again, I'm going to show you exactly what those are and how to take them correctly. No selling. The patient should diagnose themselves. And then I'll say, before I start the photographs of their teeth, is there anything you see that interests or concerns you, or that you would like to change? I'm not going to tell it right now because we're running out of time. This hilarious story about this 7-year-old boy that came in with his mother and dad when we got to the photographs of her teeth, and he was standing up there at my desk and said, "Oh, Mom, look, you've got abfraction. You've got a cavity up here. You need to get that fixed." He was just like, he'd paid attention and looked at the books, and he knew what he was looking at when he looked at her teeth. This is an example of comprehensive photographs. The full face, a smile, lips in repose, full anterior, side views. I'm not going to go through that today. See, a maxillary anterior, a mandibular anterior, you can see the decay, plaque built up on the teeth, broken fillings, decay, big fillings. Now, when a patient sees their teeth, think about it. Just think about it. The difference in this and what you're doing at the operatory. I'm trying to help you double, triple, quadruple your practice with just what you know how to do. You don't have to know what I know how to do. Just with what you know how to do, diagnosing what's before you that the patient wants to have fixed. They want to have it fixed if they can understand it. So you have, but to move on with this, you've got to become technically excellent. You don't just wake up one day and say, you know what, I'm a good dentist, if you don't have any training and experience. You've got to have training and experience. So we'll work on that as we go through these webinars. If we do more of them, we'll work on everything. But first of all, subscribe to dentistrymasterclasses.com. I don't give a rat's ass if you've prescribed or not, but if you go through those seminars, those videos, and learn this stuff, so when I go over it with you, you know what I'm talking about. A dentist.
I'm going to tell them something here.
Okay.
What we're talking about today is a delivery system of 40 years of Dr. Cutbirth's knowledge. Dentistrymasterclasses.com, I was looking just yesterday, has over 400 different cases in it. If you are not subscribed to dentistrymasterclasses.com, it only costs $40 a month. 40 years of training and expertise is compressed down into one library, 400 videos, $40 a month. It's a no-brainer. Being technically excellent can happen at your computer with dentistrymasterclasses.com. In the description, click on the link. Subscribe. $40 a month. This delivery system that we're talking about today, new patient interview, exam, consultation, is predicated on being excellent. You can be excellent, but you have to have training. That training, dentistrymasterclasses.com.
Thank you, Bill. Okay, so anyway, this, if you are technically excellent, it gives you the confidence which is reflected in your body language and aura. If you feel like you can fix anything, I feel like I can fix any dental situation that walks in my office. Now, if it's an all-on-4, I work with an oral surgeon. If it's an orthognathic case, I work with an oral surgeon. If it's endo through a crown on a second molar tooth, endodontist. But I know how to do lots of different things, and so we'll go into that later. New patient interview, non-threatening. I do it in my private office. We want to know who's connected to the teeth. By the end of the new patient exam, I want to know who the players are. What does the patient want, and how are we paying for the dental treatment? Financing, parents, other. And I want anybody connected with the finances to be at the consultation appointment. I hate a lot of wording on things, so I'm not going to go through a lot of this. But the key is the patient must clearly understand their current dental condition, factors that cause the condition, and actions to prevent the condition from occurring again. I saw a new patient yesterday. This guy was from Lampasas. He smoked, he'd lost some teeth, he's going to lose another tooth, and he had a young dentist in Lampasas that he just didn't think the guy knew what he was talking about. I said, well, I'm probably going to tell you the same thing, but what I tell you, you're going to know it is the truth. And I said, if you've got a brain in your head, you will stop smoking, because that's why you lose your teeth. We can keep the rest of them, but you're going to lose 3 teeth right now. And if you don't stop smoking, you're going to lose them all. And there's no reason to put any money into saving what you've got. So it just makes you more confident when you're talking to patients. Remember, what you do or say is important, but the way you make people feel is most critical. This guy was interesting. He was there with his wife. I always like to have the wife with the husband, because they're the ones that usually drive the ship. Men usually come in because they've got a toothache. So the woman came in and she looked at the photographs, my PowerPoint photographs, which I'll show you over time, like I said, if we do more of these. And she said, you could make his tooth look like that. I said, yep. I said, but you're going to spend 50 grand if you do that. I said, he said coming in that he didn't want to spend any money. So I'm just kind of entertaining myself talking to you now. And she said, well, I'm a retired teacher. He's retired tax guy. She said, we will come up with the funds to do that. I said, I hate the financial part. I hate that nice people like you have to pay for it. But what are you going to do? You know, you go to HEB and get groceries, you get a car, somebody's got to pay for it. We've got financing. We'll talk more about that as the courses go on. Remember, you're not selling. You're giving the patient enough information that they can make an informed decision. These are reasons that a patient should proceed with treatment. We don't want something small to become something big and expensive. As you get older, we would prefer not to be extracting teeth, doing root canals, or placing implants and bridges. This treatment is setting you up for minimum dental treatment as you get older, like that car. Just like that car. If you fix it now, you change the oil, you rotate the tires. You know, if they fix it now, they do what they're supposed to do at night, rinse with mouthwash, floss their teeth, use a Sonicare toothbrush, rinse again. In the morning, all they need to do is rinse. Watch that video on how to save your teeth for a lifetime. It tells you how to keep your teeth for a lifetime. Just do it. That's what I tell patients. Or they'll say, why not be drop dead gorgeous for as many years as possible? Decay, bone loss, cracking a tooth, chipping the incisal of an anterior tooth is progressive. Decay does not stop until the decay is removed. An implant is placed to prevent tooth migration, or a crown is placed to hold a tooth together with endodontics if needed, is placed on a cracked tooth. A composite is placed on a chipped anterior tooth. The sooner the better. Same thing with a night guard. But you can't be in a rushed environment. I always do consultations at the end of a day. And I work Monday through Thursday. And I see patients from 8 to 5. And then I'll have consults at either 4:30 or 5. The objective is I want Josh and myself, Josh is my office manager, to leave by 6 o'clock, Monday through Thursday. But I always want the consult at the end of the day, because you never know where it's going to go. You know, those people we talked to yesterday, Josh, is 6 o'clock, and it went from nothing to they're going to fix his teeth. Just the conversation. But if you're rushed, you say, oh, I got to get out of here. The timing may not be right. Now, that's just my temperament. You know, growing up in West Texas, I love a good conversation, and I think it's a vital part of connecting with the patient. Okay. Need to be able to give painless topical anesthetic. You need to be able to give a painless local anesthetic. If you can do this, you will win a patient over instantly, because they're used to being hurt in a dental practice. How many times do I talk to patients and they say, my dentist could never get me numb? Well, that's because they don't know how to do it. Watch my videos on how to achieve painless and profound maxillary and mandibular local anesthesia. It's a technique. It's a technique. It's not a volume thing. It's a technique. And most dentists, unfortunately, don't know how to do it. Okay, so this is the hard part for me. I don't ever like to present numbers, but you need to see what the possibilities are. Now, this didn't happen for me from the get-go. I started in a practice that the most productive year this guy had ever had was $167,000 total production for the whole year. When I started, I was doing my own hygiene. I didn't even have a hygienist. And so now we've expanded. It's still in the same office that guy was in back in 1981. And so these are my last 5 years, from 20 to 24. Now, I look at these numbers once a year, every December. I don't ever want the finances to cloud my vision or influence me on any case. Sharon and Bo look at them every month because they're just keeping up with it, but I don't even know about productivity until December of every year. Okay, so this was 2020. When was COVID? What year was that?
2020.
COVID was 23. Okay, so COVID, we produced 2,597,000. Let's see, what is that?
2,059,000.
2,059,740. Shut down part of the time. Then in 2021, produced 2,300,000 and change. In 2022, produced 2 million and change. And I have about a 40% overhead. In 2023, we produced 2,200,000 and change, almost 2,300,000. And then this year, from 1 to 3, the first 3 months, we produced 721,000. Now this is no sell, just presenting making it clear to a patient what their situation is and what their options are. And it's a comprehensive practice. Remember, you don't have to do something to every tooth. You're just fixing the car. Fixing the car so they could drive to California. And most people want that. You may do it in parts. You may do it all at one time. Now, I sedate people in the morning, but I've evolved to the point, in probably the last 15 years, I normally see one patient from 8 in the morning until 12:30 or 1 in the afternoon, and they're sedated. If you do those long appointments, that's another part of your training that ought to kick in. The patient should have some type of sedation because it's a long car ride. Even if it's painless, it's just a long time to sit there. Okay, so is there more after that? Okay, so is that it? All right, so that's our first and maybe last webinar, depending on what you people want to do. I'm happy to do them and go through them on a regular basis if people are interested in this type of thing, but it means changing
We do have some questions.
a bit possibly from what you're doing, and over time. Sharon's an expert at this. Come on up, Sharon. Sharon's seen every seminar I've ever given. She could really present this better than I can.
We do
And-
have some questions.
Okay.
And,
Just one thing real
yeah.
quick. We are going to do questions and answers now.
Yes.
If any of you are just tuning in now, you will receive an email later today where you can go back and watch the entire webinar from the beginning.
That was a question. One lady had to leave to go to a child's graduation. Can we watch it later? So the email comes this afternoon with a link, and they can tune in later. For how long, Bo?
It'll be up. How long?
How long are they able to go back and watch it?
Indefinitely.
Okay, indefinitely. Great. All right. There's some concepts here. We've got some really nice feedback. People want to know how you keep your overhead so low. They want to know how to transition and be able to be like you, where they're not in a corporate model. That could be another
You are going to
seminar.
be the one to talk about that because you're better at that than I am. How they you've watched them all and you've given the seminar on how to transition because you've seen how to do it. We're not going to do it today, I don't
But
understand.
there is a strategy to that, and it's something you've put a great deal of thought into, and they can do it. And the concept is that you pick one day a week and try to do this. And then possibly maybe keep it at one day a week. One day a week it's a Monday, another week it's a Tuesday.
Remember, with
and then-
me,
yes.
I'd never heard of this concept before. I went to the end and worked backward. And I said, how can patients understand their dental condition and what their options are? So at first, I just had photographs I'd taken of different situations taped into a loose leaf binder. And I did that for years. But I was always taking the diagnostic photographs of the patient's teeth. Then in 2000, when Baylor Dental School, Chuck Arcoria asked me to start the teaching center continuum at the dental school. I had to have something to give to the dentists so they could do the system. So Sharon put these books together and had them published. We've still got 100 of them over here somewhere, because these dentists had to have it to complete the system. At the time, we had camera systems they could buy, retractors, mirrors, because they wanted to do it just like I was doing it. Now we don't do the camera thing
Not
anymore.
really.
That didn't really go. It worked for the card dentist,
There's
but
a link. I mean, when they click on the picture link book, they can buy the camera.
yeah, is it Capital Camera or wherever it is anymore?
We
Who
got
knows?
Something else with them.
We just moved away from that. That was too much trouble. But anyway, okay, so I went from doing my own hygiene. That guy I'll never forget, the first year I was in practice, I went to the bank. I was buying this little bitty practice, just mainly because we were moving to Waco, and I didn't move here for that practice. We'd moved to Waco, and this practice was available. And this guy's most productive, totally productive year, it's his total yearly production, was $167,000. And I went to the bank to borrow money from Bill Kelly, was the banker's name. He was a friend of my father-in-law. And I said, I'd like to borrow money to buy this practice. He said, well, what do you think you'll produce this year? I mean, money is a part of it. That's not the motivating thing for me anyway, but it's a necessary evil. And I said, well, this guy did $167,000. I'm hoping I could do $100,000. So about 3/4 through the year, my accountant said, you're going to do over $500,000 this year. I said, no, I won't. He said, you're going to do over $500,000 this year. I said, I can't. I said, why? I said, because this guy had been here for 30 years and his best year was $167,000. But the first new patient I ever saw, I did like this, comprehensively, so the patient could understand their condition and what their options are. I've never sold anybody anything. I just show them what can be done, and they decide what they want to do. The only thing I don't do anything I can't stand behind. Because when I was younger, I did a few things I couldn't stand behind. It breaks down. And now, who's responsible? It just causes conflict. So I don't do anything I can't stand behind. Okay, Sharon.
There's lots of multi-part questions.
Okay.
Millennials that are so busy, that want their exam and their work done all at once. How do you handle that?
Forget it. Forget it. Just say, can't do. You want your teeth fixed, or you want to run through?
The dentist controls the energy.
Yeah. I mean,
Not
what
the
is the
patient.
answer? You've seen it 100 years. I
You
mean,
do not let the patient control the energy. You control the energy.
no, I have probably 25% of the patients or 30 that come to my office at the interview. I say, you're a nice person. I hope you think I'm a nice person, but you don't want what I do. What do you mean you don't want what I do? You want somebody to patch you up or just take a tooth out and go on down the road. I said, you need to go to somebody that does that type of high volume, run people through like a herd of cattle, take the tooth out, patch that thing up, because that's not what I do. You mean you're not going to treat me? Probably not. If that's how you think about it, you're not a bad person. And I support those practices. It's just like a restaurant. That's not what I do. So you got to set the tone.
So we might ask, we have quite a bit of feedback that they would like to have more detail. They would like to have another webinar. It seems that since this is foundational, the next one might be with regard to photography.
Yeah. No, I'll take you through the whole thing, but I'm not going to waste my time if you people don't want to know how to do this. I can show you how to do it. I want to give back. I've had so many fabulous mentors through the years that have impacted me. It made me cry to think about them. I want to give back. All people have to do, you've got to do something on your own though. If you haven't put anything into it. I'm not going to put anything into it. You've got to subscribe to dentistrymasterclasses.com and watch those videos so you've got a clue what I'm talking about. If you're going from absolute dirt, it's not going to mean as much to you, and you're not going to get there. You've got to put something into it. So if you subscribe to everything from now on, I believe they've got to be subscribed, right? I don't want to put the time into it. This takes a pound of our flesh to do this, in addition to doing the online thing. But it's interesting to do if you've got people that are interested. I get bored dealing with patients or dentists that aren't interested, because I'm showing, that's the only reason I show you the numbers, saying that's where we've evolved. Every year we know we're going to do about that, just based on the system. You won't do that from the get-go, and that won't be the focus for you. But if I didn't show you those, you'd be thinking, well, does this work or does it not? Because most of you went into dentistry, yes, to help people, but you also wanted to make a reasonably good living. So
There is some discussion. How can you get a hands-on course? They mentioned a couple out there. Of course, CARD was hands-on for 20 years, and that is very important. And you might consider it if there was enough.
yeah, we don't want to
Interest.
make a course. What happened was at the economic collapse in '08, we had, in every hands-on course, we had 50 to 100 in every class. And then in '09, it just died. Dentists quit going. And so we finished out, we limped along for a few years, but Sharon was one that said, we're not making classes. We're not going to beg people to come to these classes. But it was fabulous. It was the way I always wanted CE to be, because hands-on is such a great thing. We had a laboratory with hand pieces, chairs that people could manipulate into centric relation, all that type of thing. So we're not going to do it unless I don't know what would make us do that again.
Something to consider.
Yeah.
Now, there are many specific questions here that we're not going to answer today, because if you subscribe to Dentistry Masterclasses, Steve spends an hour a day answering very specific questions. And he enjoys interfacing with those people. So if you have an idea of what you might want to see next, write that now
In the comments.
in the
yeah.
comments. And
If there are
then,
topics they would like to see webinars on in the
would
future.
you address that? Yeah.
The thing is, I know what you need to know. I know what you need to know. I would teach you what you need to know in a sequential fashion. If you want to do it just to entertain yourself, write on there what you'd like to know. But I know what you need to know to have the potential. Well, the first thing we want is for you to be the best you can be, like a Marine, with the training you've got and your experience, because that's where wisdom comes from, training and experience. And so if all you know how to do right now is a composite, do the best composite you can possibly do. Now, if you plan on staying with these courses, write this down. Watch my videos on fundamentals of occlusion and fundamentals of aesthetics. If you don't understand the fundamentals of occlusion and the fundamentals of aesthetics, you are not a good dentist. And I say that because you may be a nice
You
person.
don't know what you don't know.
Yeah, you don't know what you don't know. You've got to know those things just to start. Where are you trying to get? Where are you trying to go? What do they say? If you don't know where you're going, any path will do. If you don't understand fundamentals of aesthetics and fundamentals of occlusion, then you don't have the potential to know how to equilibrate a bite, how to treat TMJ, how to treat myofascial pain, how to restore anterior teeth. So start with that. So what my plan would be, if I was you and I wanted to do this type thing, I would want me to set up a continuum. I do well with continuums. That's what we had in Dallas. and just go through this on a periodic basis. I'm not going to commit to anything till I see how this goes, and if people want it, if you folks want it, then we'll probably do it. And it would be a regular thing. I don't know if it'd
That you
be...
could watch over and over again. That's the
Yeah.
great thing about the library. You can go and watch them over and over.
When we did these in Dallas, the charge for a weekend was anywhere from $17.50 to $27.50 for the weekend. But we're doing this for you. Your only price is $40 a month. Help me. We're trying to give back. But if people have to step up and do that part, or...
Because this takes videographers, editors,
Yeah,
studio.
yeah.
I mean, it has an overhead too.
We need a little help with the overhead to make this happen. But you've got to, if you show the interest, we'll put something in. We'll put it together.
Okay.
Good.
I think that's it.
Okay, glad
Thank you
y'all were
for
with
the
us. How can they give feedback on whether they like this, they want to keep going, what? Subscribe. If all of y'all subscribe,
And then they can make comments on this.
then make comments and I'll answer them. But that's how you say I like it. Just subscribe to dentistrymasterclasses.com. Okay, glad y'all were with us. Enjoyed being with you.